Hi guys, this is Dr.B'sNotes. This is a first video where we're going to be discussing common topics which we will find on step 2 and maybe even step 3 for internal medicine. Now, all of these topics will be time-stamped in the description box. So if you don't need to see this whole video, that's completely fine. You can just go to your timestamps and listen to the topics that you might be weak in. So with that said, let's get started. I also want to add that for copyright purposes, I will not be showing some of the images that might be associated with some of the pathologies. EKGs, it's kind of hard for me to show them. But if there's anything important in these lectures, I will point it out so that you guys can, on your own time, or as you're watching this lecture, could go to Google Images and kind of get an idea of the things that I was describing. So let's get started. The first thing I want to discuss is herpetic whitlow. Herpetic whitlow, as the name implies, is related with herpes simplex virus. Okay, so you have two types of herpes simplex virus. You have 1 and 2. 1 affects more of the oral region, okay, and 2 is associated with the genitals, okay. Herpetic whitlow is usually, it's a unilateral vesicular rash, okay. So it is unilateral and it's a vesicular rash and it's associated with herpes simplex virus. A lot of times when you're presented with herpetic whitlow, it's usually that vesicular rash, but it involves the finger or the fleshy area around the fingers or the fingertips. But it can also involve the palms. But the key word is herpetic whitlow. It's going to be unilateral, and this person should have had a history of herpes simplex virus, whether it had been oral sores or genital ulcers or something that points out that, yeah, this patient has a history of herpes simplex virus, and this rash, since it's unilateral, vesicular, it might be herpetic whitlow. You need to know how herpetic whitlow looks like. All these dermatological findings, right? Derm is so important on the steps, and knowing how to discriminate between two derm conditions is sometimes very important on these exams. So Google herpetic whitlow and understand how it looks like. Moving on, let's talk about the coxsackie virus. Whenever you get a question about coxsackie virus, it's going to be a child or a kiddo, okay? You're not really going to see coxsackie in adults. Coxsackie virus, unlike herpetic whitlow, it's bilateral, okay? Remember, hand, foot, mouth disease is associated with coxsackie virus. Instead of just a vesicular rash with herpetic whitlow, you're going to also have macules, maculopapular, and vesicular rash associated with coxsackie. Again, that's maculopapular, and vesicular rashes associated with coxsackie. Okay, and it's bilateral. It's not just unilateral, it's bilateral. And it can also be desquamating, involving the hands, feet, and mouth. And most people that have coxsackie virus are kids in the summertime. Now, parvovirus B19, this is another one. With parvovirus B19, remember, it can affect both kids and adults, okay? But with adults, if parvovirus B19 affects them, they're more likely going to have some type of joint manifestation like arthralgia, arthritis. But with kids, if they have parvovirus B19, they're not really going to have those joint manifestations, aka arthritis, but they're going to present with kind of like those viral symptoms you have when you have a viral infection, along with a slap cheek appearance. So their cheeks are very red and it's bilateral. Now, another thing, group A streptococcus, again, this is an infection that can also have dermatological manifestation. With group A strep, okay, it's a bacteria But you can also have dermatological manifestations, and that is the erythema marginatum. Okay, so this is seen in someone that has rheumatic fever caused by group A strep. So this is a demarcated rash on the skin. By demarcated, we mean that the borders are very distinct and we can make out what the rash is. So go ahead and look up how erythema marginatum looks like. Go back and look at how the slap cheek appearance of parvovirus B19 looks like. And make sure you look at the maculopapular, and vesicular rash associated with coxsackie. There's also something called sebhorreic dermatitis. It kind of looks like dandruff, okay? It might be a little itchy, a little irritative. Now, someone that has widespread sebhorreic dermatitis, you want to screen them for Parkinson's, okay? So that's a key thing. Widespread sebhorreic dermatitis, you want to be thinking Parkinson's. Please make sure you know what sebhorreic dermatitis looks like. I'm describing it as dandruff, but definitely Google the image and see what it looks like. There's also something called sebhorreic keratosis. Now, sebhorreic keratosis, it's waxy and very fleshy in appearance, and sometimes it's described as brown or dark in color, okay? Waxy, stuck on, greasy, black, brown in color, okay? Now, sebhorreic keratosis, here's the kicker. You need to look up what it looks like, but also remember there's something called the lesser trailet sign. So if someone has a lot of these sebhorreic keratosis on their skin, you want to be thinking, is there some underlying cancer? Is there some underlying GI cancer? So remember that association. Pyoderma gangrenosum, okay? Pyoderma gangrenosum, okay? It is a ulcerish in appearance and affects the lower extremities, okay? Pyoderma gangrenosum has a high association with inflammatory bowel disease like Crohn's and ulcerative colitis. Definitely make sure you know what it looks like, so go ahead and Google that image. Acanthosis nigricans, okay? This is dark, it's hyperpigmented, sometimes it's described as velvety. It affects your flexural surfaces, so such as your neck, your armpits, your skin folds. You might see it there. It has a high association with diabetes, but again, acanthosis nigricans can also be associated with cancer. So there's two types of acanthosis nigricans. There's a benign type and there's a malignant type. This is what you need to know. Generally, the people that might have the malignant acanthosis nigricans, just like all cancers, age is an important risk factor. So the older a person is, the more likely they might have malignant acanthosis nigricans, which is meaning that the acanthosis nigricans is a manifestation of some underlying cancer. If the person has acanthosis nigricans and you suspect it's malignant or due to an underlying cancer, there has to be weight loss. If it's benign acanthosis nigricans, they're not going to be experiencing weight loss. If they're experiencing weight loss, the acanthosis nigricans is most likely malignant and there might be an underlying cancer. Definitely know what it looks like. Definitely know what acanthosis nigricans looks like and know how to differentiate it from skin tags, which are called acrochondrons. Acrochondrons are skin tags. Again, they can be associated with someone that's obese, pregnant, and Crohn's. So Crohn's, obesity, and pregnancy can be associated with skin tags or acrochondrons. Acrochondrons. Hopefully I'm pronouncing it right. Now, achalasia is the inability for the lower esophageal sphincter to relax. So people with achalasia may have GERD or acid reflux for 4 to 5 years. They're going to be given PPIs, but they keep having these symptoms, right? So the next best step, if someone is having difficulty swallowing or has been having this acid reflux for several years is to do an endoscopy. The reason why you want to do an endoscopy is you want to rule out some more serious conditions like cancer or some type of mechanical obstruction. Now, if the endoscopy was within normal limits, then the next best step to diagnose achalasia is a lower esophageosphincter manometry. Okay, that's where you're going to be looking at the pressure of the lower esophageosphincter. If that is extremely elevated, okay, there are many ways, and there's a sequence of events you would do to treat achalasia, but if a lot of it fails, if the initial medical treatment fails, the last resort is surgery, where you cut the muscle around the sphincter. Okay, so myotomy. Okay, myotomy. Sorry if I'm not pronouncing it right, but you get the idea. And just for a quick review, remember the esophagus, the upper 1/3 is skeletal muscle, okay, which we have control over. The middle 1/3 is a mix of skeletal and smooth muscle, and the lower 1/3 is smooth muscle, and we do not have any control over our smooth muscles. It's more of an involuntary control. So I'm going to keep these to 10-minute videos, but if you click on the next video, this section will continue, but it's breaking down into 10 video clips. So I will keep this as one chunk, and I'll label the parts so everyone can stay organized. Thank you, and see you in the next video.